kick from what I remember back in my pharmacy days on that front, where you want to be going and supporting those patients to, again, get a better control on that front. I have to say, amiodarone is something that only consultants will be prescribing and initiating. It is not something we should be doing. And also, if you look at the position statements that are out from South West London, generally, it's not something we should be prescribing because of the data out there. But this is going to be something that they need to be thinking, because that's going to be more of a rhythm control side as well, because I get that question asked me. Now, if monotherapy... Oh,
sorry, did you stop the recording?
I haven't stopped the recording. Recording's still going.
Okay, I don't know. It shows that stopped. Okay.
Mine's still going.
Yeah, I don't know. I got a message that stopped. It's okay. Ignore me.
Okay. I've still got on mine that's saying that recording is still going.
Yeah.
On that front. It's got a red dot. It's flashing at me still. So if monotherapy doesn't work, and if you're not comfortable with it being the key thing, I would send an advice and guidance to a consultant or to one of the arrhythmia nurses, and they will normally go and say to you that you can use a combination of a beta blocker with either diltiazem or digoxin in one of those three combinations, so that you can go into, I normally go beta blocker digoxin or go digoxin diltiazem. I don't tend to go and actually put the beta blocker and the diltiazem together for some reason, just because of how much of a rate controlling effect it has. I normally leave that to the consultant. So I will add in a small dose of digoxin if I need to, but I will send an advice and guidance before I do that, because it's slightly easier. And also it covers me in that front. So that's what I tend to do. Now, where you've got, for example, rhythm control with this particular patient, where you've got that more active patient, you've got that patient who potentially was a sports runner and has been running a lot on that front, has that irregularity that's occurred because of that, potentially that pressure that happens on the left atria when you are training and you are quite heavily exercising at times, and you reduce that down. For those particular patients, rhythm control may be more beneficial. So you're looking at kind of with medication, so with your amiodarone, your flecainide, those kind of things, you may be going and looking at, for example, going and putting the patient onto having an ablation, or going and having cardiac resynchronization therapy. So those patients should always be referred to secondary care services for assessment. And then we get on to the assessment of anticoagulation. So if you take nothing else away, initially in primary care, we want to be thinking about going and trying to rate control where we can and where it's appropriate, and anticoagulate, again, if you're not able to, referring to someone who can anticoagulate on that front. And we know that, especially when we're looking at the MIS agenda as well at the moment, it's about going and making sure we are prescribing people with appropriate anticoagulation and also most cost effectively. But at the same time, when we're looking at that whole side as well, that NICE have actually come out with first line DOACs should be used where it's most appropriate on that front, because it's more convenient, less frequent blood tests are needed on that front. There's no dietary and very few drug-drug interactions, much simpler procedure or anticoagulation effects. So remember the days back when we used to have to go and get a patient who was on warfarin, INRs done before they had to get a tooth taken out. Those are much simpler to manage on that front. It's as effective, if not more effective, depending on the type of DOAC that you're on, and it is safer with respect to bleed risk as well. Now, when we're going and looking at these particular risks in itself, and we're looking at kind of the TTRs and a patient on time spent in therapeutic range, which is what your TTR is effectively, the gold standard in essentially by NICE is that we want to be having a TTR of about 65 to 70%. So when we're looking at this, that would be approximately this black line. So if those patients are really well controlled, those are on that kind of level where you're looking at kind of that 70% criteria in itself, that black line and that green line. Anyone who's falling ever so slightly short of that and has been on therapy for a long term actually is beneficial for them to be on absolutely nothing. And how many patients do you have that will yo-yo between one INR to another and are not staying within their control kind of numbers? There is quite a few patients out there who still do it even now. So it's imperative that these patients are put on to maybe a DOAC, but even these patients, we should be having a conversation where clinically indicated to make sure that they are transitioned if it's appropriate for them. But it still mind boggles me when I look at this, that with this particular slide in itself, that actually it's benefit for the patient to be on no warfarin at all rather than be on badly controlled warfarin. So if you've got someone who is badly controlled, think about how we go and assess that patient and if it's appropriate to change them across to a DOAC. Now, going back to that ABCD ABC pathway, no, there's no D, ABC pathway in itself, the anticoagulation to avoid the stroke side, we need to be offering anticoagulation. So making sure that that patient has got, if they've got a prosthetic mechanical valve or moderate severe mitral stenosis on that front, they should not be going on to a DOAC in itself. So those patients straight off the bat need to be referred to anticoagulation services, or if you manage warfarin, they need to be initiated onto warfarin on that front straight off the bat, and they need to remain on that. Now, if you've got those patients who are going to be going and reviewed, you're going to be doing your CHADS-VASc score on that front. So you do your CHADS-VASc to identify anyone who's on low risk of stroke. So for example, has a CHADS-VASc of 0 in males or 1 in females. If they fall into this kind of side, they don't need to be put onto antithrombotic therapy. So they don't need a DOAC. But what the gold standard again says, and the good practice is you review them every 6 to 12 months just to make sure that that person is going and actually being assessed in case any of their risk factors, anything else has changed in that front. At the same time, anyone who now falls into a CHADS-VASc score of 1 because they're male or 2 if they're female, and obviously you want to first and foremost address any modifiable risk factors on that front, which I'm going to go through on the next slide. If they have a CHADS-VASc again of 1 if they're male or 2 female, oral anticoagulation should be considered. I tend to start all of these patients on a DOAC. I don't consider it. I will recommend it. And anyone with more than this should definitely be starting that. So when we look at these different assessments on that front, your CHADS-VASc criteria here on that front is, so looking at the CHADS-VASc, so your congestive heart failure or left ventricular dysfunction, hypertension, age, diabetes, they've had a stroke, TIA, or any thromboembolic issues previously, vascular disease, age again on that front, if they're above 65 to 70, or if essentially the sex as well of that patient. In terms of the way that it tends to work as well, we've got 2 different kind of criteria, which we always look at has bled historically, of patients' hypertension risk, going and looking at your renal disease, your liver disease, your history of stroke, and You can read the screen essentially. And the newer score, which is Orbit, which still isn't been embedded into clinical systems, and I have to manually calculate every time, which is really frustrating. However, your has bled will give you your overall risk of even your minor bleeds. So I tend to use both of these on that front. So it gives you your minor bleeds parameters, and if there's going to be any complexity, so your kind of bleed risk on that front. However, your Orbit will give you kind of the validation, and is also used in an era of DOACs, where DOACs existed, because has bled was more when there was warfarin around. Your Orbit score goes and tells you your risk of a major bleed occurring on that front, which is why it's really important to use Orbit as well, to make sure that you are balancing out that risk as well. So that's why there's been this transition in itself from NICE to recommend to go and use Orbit, because it's a higher accuracy of predicting absolute bleed risk rather of a major bleed rather than of those minor bleeds. It helps with those decision making rather than overestimating a risk, which will look like really high risk when actually the patient may be relatively low risk on that front, but as a risk of having minor bleeds, like a nosebleed, for example. And it goes and allows you to have that conversation on that front as well as Orbit being the best thing and for its purpose, going and assessing those patients on electronic systems, but we're still waiting for it to be embedded. So until then, use MD Calc. Now, what I'm going to do, because I think it's really imperative to go and try and put this into practice. I can talk at you all the time. I can even see Hala's probably bored listening to me talking at times. But we're going to apply this to Daphne. So Daphne is your 81-year-old patient. She's female. She weighs 72 kilos. Her medications are perindopril, bisoprolol, omeprazole. She's got hemoglobin of 13 grams per deciliter. So that's about 130. Her creatinine is 140, so that's all right on that front. A little bit higher, but not crazy high. Her urea is okay. It's about 9. Not crazy high. Again, a bit more than the average, but not too high. ALT, AST, and INR are all within normal range, so nothing to worry about. In terms of her medical history, she's the first episode of atrial fibrillation. She's been referred for consideration of anticoagulation. She's had the palpitation side on that front as well. And note she's on bisoprolol. She has a hiatus hernia, which is why we're on the omeprazole in the first place. She's got diabetes, which is non-insulin dependent, and she's got a history of hypertension on that front too. Now, when we're going and looking at this particular patient as well, I was going to say, how is she on perindopril 5? They only come in 2, 4, 8 from what I remember. So I don't know how she ended up on a perindopril 5, but there you go. I might have to change that for next time. She's got mild heart failure on that front. Again, left ventricular ejection fraction of 49. So she's had her echo. She's got mitral regurgitation, but no mitral stenosis. So that's a really important thing to remember. She doesn't drink alcohol, no previous hemorrhages, and her BP is about 120, 90. Doesn't like taking too many tablets. Who does? Hates needles and uses a Dosset box. So this sounds a lot like quite a few different patients. So the first thing that we do is we work out a CHA2DS2-VASc score. As you can see, that's quite significant on that front. So it's 6. Because of her female, because she's aged, she gets 2 marks because of the diabetes. She's had a history of heart failure and hypertension. So for that reason, her risk, and when we look at it, it's about 20% annually. So that's 1 in 5 people with this risk will have a stroke. So that's a significant person. So we definitely need to be considering anticoagulation. We then want to be thinking, what's her Hasbled and her orbit? Actually, her Hasbled is about 6, is 1, and her orbit is 1. So which puts her in the low risk category for both sides in itself. So Daphne needs to be anticoagulated. But what do I do next? Because that's going to be the next thing that's going on in my head. So most people refer her to anticoagulation if they can't initiate her. But if, for example, we needed to go and think about what's the most appropriate thing we need to be doing and we're going to initiate, you've got to think about practical considerations of who would benefit comparing it to warfarin. So according to the data, a patient needs to have a full 295 days in a year to have for the benefit to outweigh the risk of going and not being on anticoagulation, but actually on a DOAC on that front. So actually, you need to have a full every single day, apart from weekends and bank holidays. This year I can say, no, this year, no, I can't because Charles' coronation. So next year, they need to have a full on every single day, apart from bank holidays and weekends, for them to not be on anticoagulation. And if they had a high alcohol intake, they're on brittle tracting drugs. So, for example, brittle COPD, who are going to need multiple courses of antibiotics. Needle-phobic patients who don't want to have multiple blood tests are going to benefit from DOACs as well. Commuters or housebound patients, difficulty with attending or more regular monitoring, and variable doses. Now, people who should not have a DOAC are going to be these patients. So your prosthetic mechanical valves or your valvular AF. Valvular AF is only going to be those patients with that moderate to severe mitral stenosis. Everyone else is non-valvular AF. Certain hemolytic conditions, so if they've got antiphospholipid syndrome, but actually there's evidence now coming out to say that that actually may not be a problem going forward. But watch this space for that one. People in prothrombotic states, so we've active cancers or on chemotherapy, unless their specialist has said they need to be on it. People on triple therapy, so dual antiplatelets, so dual antiplatelets plus warfarin, unless again they're advised by the specialist, and normally the specialist will say they'll need to be on aspirin and clopidogrel for 1 month and then drop probably the aspirin and carry on with clopidogrel, or vice versa, and then you carry on with the DOAC alongside. People who have an INR requirement above the standard range of 2 to 3. So if a patient has a requirement where they need it above 3.5, above 3 to 3.5, sorry. So between 2.5 to 3.5, those patients should not be considered for DOAC, and those are going to be mostly those patients who have got those mechanical valves on that front. Pregnancy and breastfeeding, patients with severe renal impairment, so that creatinine clearance of less than 15. People with severe hepatic impairments, if we go on to our MD Calc, people with Child-Pugh score of B or above, so when you calculate it out, is a Child-Pugh score of P or above, should not be on a DOAC. They need to be considered probably for warfarin, but more likely for low molecular weight heparin. Significant interactions with the DOAC, which is going to be dependent on those particular medicines. So it's going to be very few and far between patients, and people with extremely high body weight. That's a question mark these days, because now actually our trust guidelines tend to allow us to prescribe above that, but we need to make sure that they are falling into the correct criteria and they've been evaluated by hematologists. So that's not something I would be initiating. It's something that they would initiate, and then we would continue from there. And people with thrombotic states in unusual places. So for example, in portal vein thrombosis, it's not actually something that we should be initiating, something that a specialist should be. So those particular patients who you want to be referring on that front, for just as a rule of thumb, if you're new to this, people with a GI bleed or gastric ulcer bleed last 3 months, with intercerebral hemorrhage in the last 6 months, severe menorrhagia, so severe bleed. Is there something wrong, Hannah?
No.
Oh,
Just
okay, sorry.
reading the word.
Sorry.
No, it's fine.
No, that's fine. I heard a noise. So known bleeding disorders, people already on dual antiplatelets, those contraindications that I've already said, weights below or above those kind of weight zones, dialysis patients, they should not be on a DOAC. They need to be on warfarin on that front, or low molecular weight heparin more likely. People with bloods in last months with more than 1.5 times of the upper limit of normal for the bilirubin, the LFTs, people with platelets of under 100 need to be under hematology, an abnormal clotting screen, or HB, which is low. So potentially they've got a bleed going on for no identifiable cause on that front. So we want to be making sure these particular patients are referred as a rule of thumb. So first things first, we need to think about pre-screening. So before we start the DOAC, in the last 3 months for me, I would want to have done a full blood count, a clotting screen, or an INR for switching across on that front from warfarin on that front. If they've had a normal clotting screen in the past, I will take that as well, because it's unlikely that would have changed, because we're looking for if they've got any hemolytic conditions. Urea electrolytes on that front. You want liver function tests. You obviously need their weight, because you need to work out in terms of their creatinine clearance, and a blood pressure, just to make sure that we're risk assessing for that bleed risk as well. When you're discussing it with the patient, you want to be going in terms of why are we actually putting them on the anticoagulation, explaining the pros and the cons of DOACs and warfarin. I always use warfarin because that's the one that everyone first, even now, thinks about, is I'm going to end up on warfarin. And actually saying, yes, there is a risk, but actually this is a much lower risk considerably. And the likelihood of a bleed risk, again, because of the risk of a previous bleeding history, are they actually going to take the medicine? Would they be better for them to be on something else, or do we need to consider not prescribing it for them because they're not actually going to take the medication, or they may take too much, which increases their bleed risk on that front? You want to be specifying the name of the drug, whether it be generic or brand on that front. But a key thing now is that actually there are generics available, which makes things more cost effective to prescribe. So we're moving away a little bit from just plain edoxaban prescribing like we were previously last year, which I saw coming, but that's a different story for a different day. But you want to be going and explaining how often they need to be taking it, the short half-life, so it's important to take it daily on that front. Duration of therapy, so again, is going to be indefinite for AF, and whether it needs to be with or without food. So with Daphne, you'd be talking through all these different things. For missed doses, so for edoxaban, rivaroxaban, they can still take it within 12 hours if they've missed that morning dose, that they take it every morning. For apixaban or dabigatran, they've still got 6 hours to still take it before they have to miss the dose as well. And then going through the different kind of side effects, obviously if they've got a clinically appropriate going through pregnancy and breastfeeding, storage of the medicine, as well as trying to make sure that they're not on anything other medication. And really important is making sure that they're aware they should be avoiding NSAIDs and to check for herbal medications to ensure that it doesn't interact. The amount of patients that I find who come in who are still taking NSAIDs is ridiculous, and it's one of the highest risks for patients ending up in hospital in A&E with bleeding. Now, the biggest concern that we have is, what should I be worrying about in terms of bleeding on that front? We know that bleeding is going to be the biggest concern on that front. So what we need to be going and saying is, actually, you're having looked at your has bled and your orbit, your low risk or medium risk or high risk or whichever risk you are, and not be like this lovely picture that's here saying that I'm an artist, I'm going to figure it out and make you feel happier, because that's not going to work. But going and explaining, actually, if you're having any unexplained bruising for no apparent reason, avoiding any contact sports, if you're having a self-terminating episode, for example, with a kind of a nosebleed, I'm not too worried. If you've had a bleed from your urine or from your back passage, from your bowels, I need to make sure that actually I'm checking you out to find that there's nothing else going on in the background as well. So is there potentially another issue on that front? Is there prolonged, recurrent, severe bleeding or head injury? Are the major bleeds can be managed and reversed in itself? There are reversal agents for a lot of these medicines, apart from for dabigatran now. But generally, they tend to go and use supportive measures in itself, because the antidote's not as readily available. So in our local area, I think St. George's has it. Potentially Croydon has it as well for the antidote. Kingston, I'm not too sure about on that front. But there are antidotes for those severe bleeds in itself nowadays, but it's not as readily available. So people do tend to use supportive measures. So if they needed a blood transfusion, they could still have that going forward. And then going and thinking about other practical things. So if they are frail or they've got previous history gastro bleeds, we want to be adding in a PPI on that front to protection gastro availability side. We want to be making sure that DOACs, where they need to be taken with or after food, are advised as much. So in terms of rivaroxaban, dabigatran, we know that they can be gastric irritants and they can cause issues, or there's issues with absorption, for example, with rivaroxaban. So we want to be going and putting that person on that medicine first and foremost. Now, if the patient has a gastric irritant, for example, they're on steroids, aspirin, SSRIs, bisphosphonates, we know the list of medicines. Again, thinking about gastroprotection, or count as a minimum, explain to that patient, we need you to make sure that you are eating with that medicine. Now, if we look at Pincell, we definitely need to be, for aspirin specifically, we need to be going and making sure that person is on gastroprotection to cover them for a risk of a gastric bleed, because it is significantly increased. I've gone through the missed doses and compliance on that slide, but making sure for those patients who've got dementia, memory issues, compliance issues on that front, that those patients are put onto drugs and DOACs that can be put into those MDS kind of sides or DOSIT boxes. So apixaban, doxaban, rivaroxaban can all go into that. In terms of kind of advice and guidance for patients on that front, anticoagulation cards need to be made sure they're given, so they carry it with them, so that if they were to have an accident or something where they couldn't communicate that they're on this medicine, that actually then they can have that in their wallet or their purse, and they can be kind of flashed up so that medical services know that that person is on that medicine. Giving them the right AF booklet or a leaflet. So I've got a leaflet that goes and tells people how to manage your AF, and at the same time goes and tells patients what we need to be going and thinking about in terms of anticoagulation if you've got any concerns. And I give them a one-pager about the key things. So if you've got any severe bleeding, any bleeding from any area that you're not expecting to be bleeding from, a nosebleed that lasts for more than 10 minutes, those kind of things. If you're a woman, if you're bleeding from your vaginal area and you've gone through the menopause and that kind of thing, or if you're having a severe bleed, full stop, if you're of childbearing age patient who's a woman, those patients, so they know exactly what they're looking for on that front. If they're going and seeing a dentist, a chiropractor, vaccinations, because now everyone seems to be doing vaccinations, tell them to tell the person who's doing the vaccination that they're having the injection. Because if we remember correctly, we previously used to give it a 45-degree angle when we first started giving COVID vaccines. Now, not so much of an issue, but we need to make sure that we are going and telling those patients. Same thing with our dentists, making sure our dentists know if they're getting tooth extractions, minor surgery, they may need to stop the medication a little bit earlier before going ahead. Now, that is all that information is on NICE-CKS if you want to read it as well, and depends on the level of that surgery that they are having, so you can give that advice to those patients as well. And also where we need to discussing it with hematology or anticoagulation clinics, so that we can give the right advice to all the right patients. So let's go back to Daphne. We know that these are the medicines that she's on. We know in terms of her bloods, she's okay a bit. So we've got a little bit of CKD creeping in, but not massively on that front, because her creatinine is about 140. But it's not massively. Now, the first thing I need to think about is her creatinine clearance, because I don't have her weight there. Now, for Daphne, we had these bits, but depending on what her weight is, on that front, if it was in the 70s and it wasn't up to date, this would be saying that her creatinine clearance is about 31. However, if her weight was about 50 kilos, it'd be down to 22. So that would then change obviously your other dose options. If her weight was 90 kilos, it would be again about 40. But if she was 100 kilos, for example, it'd be well over that 50 mil per min, where we want to be reducing down that dose if she was put onto a doxaban, for example. But for the option of Daphne, her creatinine clearance is 32 milliliters per minute, which makes life a little bit easier. And we always go by actual body weight and not by going and changing that patient to ideal body weight. So you go by what the actual body weight, because it can underestimate doses that patient needs going forward. But this slide is meant to show the importance of making sure we get an up-to-date weight. We have patients whose weight drastically changes in the course of a year. Now, whether that's because they've been on a variety of different medications, on a diet, or just had poor health, so we need to make sure we are updating these weights to make sure we're not missing anything, so that we can make sure that they are on the correct doses. So the old age question, to treat or not to treat, what do we start or do we refer on that front? And when we're thinking about the different things, when we're looking at Daphne on that front, we've got to think about where we're going to go. So she's 81 years old. So the dabigatran dose switch is 110 above the age of 80. Her creatinine clearance of 32. So for all 4 of her DOACs, she would be going and having a different function. However, we can't give her dabigatran because below a certain threshold, we shouldn't be going down that route because she would need much closer monitoring as well on that front. She has dyspepsia because of her hiatus hernia as well. So you want to be kind of avoiding a dabigatran and caution with rivaroxaban because that can cause underlying issues for her stomach and with the irritation in itself. She has doesn't like too many tablets. She doesn't want that on the DOAC box on that front, so we need to be avoiding warfarin for her. At the same time, oh, have I got someone messaging me on the Teams chat? Oh, someone else. It's fine. We don't need to worry about that. She's got a DOAC box on that front, so we need to be avoiding.
I have a question.
Yeah, go for it.
Before Ibrahim leaves. So on Southwest London, the DOAC should be initiated by specialism. Can pharmacist, pharma technician initiate? Now you need to, the reason for initiation is due to financial issues. GPs are pushing it back because they want to be paid for the initiation because it takes 3 months to do another review and to monitor. That is the political side of things. However, if you have a patient and you have a confirmed AF and you know that it's going to take time for you to refer to anti-coag and for it to be initiated, from a legal medical point of view, you should initiate it. So you need to protect yourself legally, that why you're not protecting this patient, why you're leaving them without this DOAC for a period of time. So there's the two sides of the coin, unfortunately. It might be a good idea to discuss it within your practice to see what is the direction that you want it to go. What is the consensus between the partners and the prescribing lead, if they're happy for a clinician to prescribe it and initiate it. Chadney, any thoughts?
And I would agree with that. I think the other thing as well is actually there's a locally enhanced service out of the 6 boroughs in 4 of those 6 boroughs anyway. I think it was 5, but I don't want to go and say that one just in case. But I think there were 2 boroughs who hadn't signed up for it in total. But actually that we should be initiating in primary care anyway. So although we have the South West London guidelines where it should be initiated in hospital only, definitely for where we've got a PE DVT because they need to confirm the duration of therapy, that needs to be anticoagulation initiating because they'll need the loading dose and then they'll need the follow-through dose on that front, and then they'll need to think considered of if they're on short-term therapy, long-term therapy, and so on and so forth. However, for AF patients, it is something that we need to be considering, and I would go for a practice approach or a PCN approach on how that your practice or PCN want to go ahead on that front, because the guidance actually is that we should be initiating them as soon as possible. Now, if everyone is against obviously initiating, please do obviously refer to your anticoagulation clinics, but our presentation is there, one, to help you with the South West London MIS side. So if you need to switch someone across from one to another, which we can do in primary care, or if you need to go and actually consider initiating the patient on the most appropriate DOAC if your PCNs or your practices come under the locally enhanced service on that front. There may be a named person, but this may also be something that you're going to be considering going forward. Does that help, Hala?
Yeah, I think we had that conversation in our own practice because we were in 2 minds if we should refer or not to refer. And I think still till this day, we have some GPs who say, no, it's a specialist only and we should refer, it's extra work. And some others like to prescribe it and, and then refer for any further issues.
So in our practice, for example, I'm the lead. I end up initiating. So I initiate on that front for AF because we fall under that locally enhanced service where GPs are getting paid for initiating on that front. So I think Merton doesn't have a locally enhanced service. Otherwise, the payment side doesn't make a difference on that front. But in Kingston, Richmond, for definite, we do. So we should be initiating. We shouldn't be referring on that front. So there should be a lead in each practice, as a minimum in each PCN, who will initiate on that patient, unless it is a very complex patient where we would then go and refer on that front. For example, if they had mitral valve complications or if they had severe low hemoglobin on that front, or there were some other issues, or they fall into those other categories. But we would generally initiate, for example, in Kingston, Richmond. So it's different depending on what area you work in. There shouldn't be, but it is. So as far as I'm aware, it will be changing and transitioning to DOACs will be initiated in primary care going forward. And that is something that they are looking at already in the background in the ICB, I'm told. So in terms of Daphne, for example, what are we going to be considering? And can we maybe get a couple of people just putting in the chat With the guidelines, with the evidence, what we've got, what are we thinking? Creatinine clearance of 32, no major contraindications or any issues. What are people thinking? What would we initiate her on? Anyone saying anything, Hala?
Not yet.
Let me make it a little bit easier. So if she was on warfarin, this is how we would transition her. There's no contraindications for her to, if she was on warfarin, for her to be transitioned across to a DOAC. So no matter which DOAC we went for, on that front, you've got the option of going and initiating her across. So we would have a decision of from the VK to DOAC, we discontinued the warfarin, measure her INR, check her levels, and then we'd start accordingly. Now, I have had patients who have been, for example, over here, and we want to put them on edoxaban, which needs to be here. So I'll give them 1 day of rivaroxaban, and then I switch them across to edoxaban the next day on that front. But it's your call how you want to do it. If you go by the EHRA guidelines, which actually came out on that front, of a pragmatic approach on how to go about it on that front, it actually gave us the evidence that the approach to, so we don't have to go and check regular INRs for patients in itself. If the INR at the time of taking the warfarin on that front was less than 2, you can commence a DOAC immediately. If the warfarin was stopped, for example, last dose was yesterday, we could start the DOAC immediately at the same time she was taking the warfarin. If she was on an INR between 2 and 2.5, you could commence immediately or on the next day. So I'd probably go the next day. And if the INR was between 2.5 to 3, I would then recheck the INR on that front between 1 and 3 days and then initiate a DOAC at that point. But that tends to go and assess it on that front. So I would generally tend to get the INR as close as possible on that front to be able to assess. If you're concerned about this particular patient and going and thinking which DOAC, which place, what dose, this, that, the other, this chart tends to make it really easy with explaining what dose I need to be going for, where I need to be reducing down and assessing. And you'll see for the 3 main DOACs, so apixaban, edoxaban, rivaroxaban, the dose reduction generally for the once dailies is less than 50 ml per min. Anything below 50 ml per min, you dose reduce. The dabigatran, I'll be honest, I don't tend to use very much of, but is a bit confusing when it comes down to this. But you can only use this up to the 30 ml per minute, and then it's contraindicated to be used. For apixaban, you use the same dose, so they get the higher protection at 5 milligrams twice a day, unless they're above the age of 80, their body weight is less than 60, when their serum creatinine is more than 133, then you would reduce down the dose to 2.5 twice a day. Same thing as a caveat for edoxaban, if their person's weight is less than 60 kilograms, or they are either on cyclosporin, dondrolone, erythromycin, and ketoconazole, we reduce the dose down to 30 milligrams. But again, you can have this, you'll have this in itself if you want to have as a reference source. You have got this guidance that came out last year as well with how to go and actually review kind of the commissioning recommendations, where last year actually the big driving factor was to drive edoxaban first line, and this was how to initiate in non-valvular AF. So where you had new patients coming in, and this was a national guidance and national flow chart that was given to us for initiating in primary care. So is the patient anticoagulation warfarin mandate, and you can go all the way down and it will tell you whether we need to think of warfarin, whether we need to be thinking about the dose adjustments in itself. This also has another page separately of where we should not be considering different DOACs and things as well, which is worth looking at. Now, the other thing I'm going to bring up, which I think is really important, is actually the South West London Medicines Incentive Scheme is actually going and saying for making sure we are managing DOACs incredibly importantly. Last year, it was all about going and making sure patients were initiated onto edoxaban where it was clinically appropriate. However, in terms of value and best support that's out there for the patients, this lovely table that they've gone and shows that generic apixaban, which is now available, is the best value for twice a days. So generally, if we can switch anyone from dabigatran to apixaban, you're laughing on that front. And your edoxaban is your best value once a day treatment. But actually, the best value overall is your generic apixaban. We should not be prescribing by brands, generally speaking. It should be prescribed generically, because in terms of the bioavailability for these particular medicines, it's not that much of there's no difference. Essentially, it is bioequivalent on that front. And with the MIS scheme, with the way that it has implored and has come through, We should be going and doing best value generic prescribing for apixaban and edoxaban as percentage of all DOAC items on that front, excluding any oral liquids that we need to prescribe, which generally we don't tend to prescribe anyway. So as long as if you're prescribing, if you're prescribing your apixaban or edoxaban, I wouldn't worry too much. The key areas to go and tackle would be, for example, where patients are prescribed rivaroxaban or dabigatran or prescribed branded Elquist, which is branded, excuse me, before I start sneezing, a branded apixaban, which is Elquist, which they should not be prescribed on that front. Within this document in itself, there are a variety of different actual areas in itself. So the NHS Procurement Directive, which is what I just had the page before, where you've got the next highest dosage on that front is a ranked DOAC. The other thing I am going to say, which I don't think South West London guidelines are potentially going to like on that front, is that they may have potentially be changing the guidelines because there may be a generic version of rivaroxaban coming out. It hasn't come out yet, but it's on its way, I'm told. So this may be a kind of watch and wait kind of issue, but I wouldn't be looking at switching across patients across onto random brands for no reason. I would be thinking apixaban is the safer option out of all of them. And if patient can be transitioned to apixaban, that would be better. Now, I think it's a win-win on one side that it is safer. And previously we were told not to prescribe apixaban if we could avoid it. However, if you've got a patient who's already on apixaban, then you're laughing on that front. However, we do need to be careful that we are prescribing generically and also we're doing what's right for the patient and about what's going to be most appropriate for the patient. The other thing that's going to be imperative as well is making sure patients, just like we have on our cough side here, patients are actually prescribed an anticoagulant where clinically appropriate. And I think that's going to be the most important part going forward, is actually making sure that they are on anticoagulation rather than on nothing. Again, where clinically appropriate, because that is part of the long-term NHS long-term plan, as well as the actual PCN directives that are out there as well. And that is the end of my conversation with you guys, which hopefully didn't overrun too bad, because I know we're running a bit behind on the last session.
Thank you so much, Chadney. A really useful presentation, very detailed about the different options of DOAC and how to assess and different patients. Now, I recently had a patient who is end of life, really hard to bleed. She's on warfarin, and she is atrial fibrillation. And then I had a query from one of the GPs if we can change her to DOAC. Her LFTs were extremely deranged, and I couldn't put the advice to change her. So they had to reach out for advice and guidance to see if we can change her to a DOAC.
And I think that's fair. I think you need to do what's clinically appropriate and what you feel comfortable doing. This is not about going and just doing blanket change for everyone. You need to go and think about what's going to be appropriate for that particular patient. And if you don't feel comfortable, you shouldn't be doing it. And that's the first and foremost side. I think it's tricky, especially for the, I'm getting a lot of patients who are on warfarin who are comfortable or stable on that front, which you go and actually assess, where you're going and reviewing those patients. And you're thinking to yourself, why weren't you switched before? Made life easier. But actually, some patients still like the idea of having that interaction with warfarin. So I think with going and having healthcare professional interaction. So it's a balancing act across the board. I think definitely where you can switch them, for example, where they're on warfarin and they are definitely going to benefit from that and they're struggling with bleeding and struggling with that, absolutely, if it's appropriate, then I would be going for it. But you can follow the EHRA guidance, because that's what we were following during COVID, and that makes it a bit easier on that front. But absolutely get that advice and guidance. For me, anyone who's harder to bleed is potentially at higher risk of a bleed as well, you've got to think about, because they've got minimal amount of circulating volume as well. So we want to be making sure that circulating volume is not causing more issues for them. So just be aware on that front, and then be careful, and potentially apixaban is probably a safer bet overall. Also has a much better risk of less likely to get ischemic hemorrhage on that front. I've got a couple of questions, a bit of a backwards and forwards between a couple of colleagues on that front who are helping. Let's have a look. So let me go through these quick questions. Could be Coversal salt form. Simon, you were very right, probably was Coversal, but I probably would have transitioned them to 6 milligrams for the perindopril, to be honest, all down to 4. But that's just me. Leave a question here, specialist primary care. Thanks for responding. But would it be a GP or us who are going to be doing this? And what additional training can make us competent? So I think when you're going and looking at the additional training, so whether you've done maybe an academy approach, we're going an academy approach on going and initiating anticoagulation. You've gone for an effective training assessment. Have you got a mentor who you can go to support you with this? See what support is out there and see what makes you happy. As a prescriber, you need to show that you've done enough to show that you're competent in a particular area. So it doesn't mean just going and attending a particular webinar. There are particular training days that you can go on, which will go through the whole thing. So I went on an effective training day, which was with one of the consultants from the hospital, as well as one of the GP training leads, which allowed me to go and then prescribe on that front, as well as multiple other training courses and that I've been on as well, which helps. But it's about going and balancing and making sure you feel confident and competent in that area. I think it probably helped that I did my specialism in cardiovascular side as well. There's a question here about why is it not recommended for edoxaban if you've got a creatinine clearance above 95 millisecond? So someone's written, I'm not saying names here. Evidence that it's effective in high creatinine clearance. So I've read that, but what's the evidence? Not sure of actual, but SPC says edoxaban should be used in patients with non-valvular and high only after careful evaluation of individual thromboembolism and bleeding risk. Right. So in terms of the actual engagement, when you look at the trial data, because this was done on a trial basis, not actual real world data, on the trial data, in order for it to remain at steady state in itself, for the edoxaban, it was clearing too quickly out of the system because of the creatinine clearance, because of hyperfiltration rate. So because of that, the edoxaban was not circulating in the system for long enough in order for it to actually be able to avoid and prevent thromboembolic strokes, as well as clots generally, which is why it was not recommended to be used at creatinine clearances above 95 on that front. I think that's where the issue occurred in itself, and that's why we were told not to go and prescribe above 95%. I have to also say the key problem that we have is that Lixiana used 95 and actually went and did those studies above creatinine clearances of 95. A lot of the other DOACs didn't. So therefore that actual information is not published. So they cannot be said whether they can or cannot. However, because that information is published for edoxaban in itself, for AF specifically, that's why we aren't able to go and do that. There have been studies for higher creatinine clearances for apixaban, where it is staying at a steady state for where you've got DVT or PEs, where it will stay in steady state, and therefore it will then stay at that level for if you're using it at higher thresholds. So it will then stay in that station at a therapeutic level, therefore preventing that stroke or that clot from developing. Whereas edoxaban, it was less effective at maintaining that level, which is why they tend to say it's not as effective on that front. I hope that helps. This is from looking at far too much data. I look at data, it's not good on that front. Hopefully that helps to answer the question that actually there is evidence out there to say that it just doesn't stay at steady state above 95. And then because of that, it's not as effective because it clears too quickly with hyperfiltration. That's the summary rather than me waffling on that front, because I can probably keep going on about this far too much on that front. But I'm hoping that was helpful one way or the other. Are there any other questions on that front? And don't feel obliged to have to do this if you don't feel comfortable. This is going to be one of those things you need to do at your own pace. I tried to do it as a case study so you can see how you would apply it and how you would go and assess it on that front, because that's how I learn best as well, as that I apply it to a patient more than anything else. So I'm going to go back to our mentee as ever, because mentee is our best friend, or my best friend today anyway. So we did this one on that front. How useful or helpful did you find this session in itself, if you've still got your mentee open, that is, on the atrial fibrillation and DOACs? Hopefully, I'm hoping you guys thought it was helpful on that front, because we were asked to go and do it. So I'm hoping that it helped on that front. So people are saying just right, which makes life easier on that front. Makes me feel a bit better that I've hopefully hit the right kind of target side. Hopefully people have still got their, what's it called? Their Menti open even for that matter. I'm going to give it just 30 seconds so it's there on that front while we get that kind of side. I didn't want to go into too much detail, but in terms of if you're transitioning from one DOAC to another, which I realize I didn't put a slide in, but it is in the actual NHSE framework. If you are transitioning from one to another, you just transition the patient across to the same time they would take the next effective dose. So if you're going from a BD to a once daily, you would go to when their first dose is. So if they would, for example, had their first dose in the morning, when their next effective dose is when you would initiate on that front, rather than going and waiting. So I always say take your evening dose and then transition the next day to your OD dose on that front. That has, I think, finished with the timing, she says. Only 8 of you. Where has everyone else gone?
I don't know, very quiet group today.
I was going to say, very quiet. I think everyone's on the South West London webinar. Was that case study and using a case study approach helpful? And is that maybe something we would go and do more of in the future? Was that helpful for you guys? So was it somewhat helpful? Was it not helpful? Should we do more of them? Should we do less? So it was somewhat helpful. Okay, fine. Okay, so it was helpful. Okay, so maybe try and use a case study approach or don't do a case study approach. So a bit of a mixed bag. Okay, fine. Is there anyone else out there who wants to go and break the tie off? She says. I'm going to give it another 30 seconds.
50-50.
And I think that's fair. I think that's fair, to be honest, because not everyone's going to learn the same way. I've always learned the case study approach, so I always tend to go down the case study approach, but that's fine. I just think it's better than someone talking at you sometimes. But I think everyone has a different way of engaging and learning that way. So I think we're going to go for an even keel on that front. We're going to try and do maybe a mix of both each time, which hopefully makes, I think the just right just clinched it just on the front, but that's fine. We'll still use a combination of everything. And thank you for the love, whoever's sending it. So in terms of kind of the next kind of side for you, so reflection on today's session, how do you feel about supporting patients on your kind of the clinical areas that were covered today? So not just maybe the side of going and thinking about the DOAC side, but what about the actual other side, the sodium valproate side, the topiramate side? I'm a bit daunted by that, I'll be honest. I'm a bit daunted by the topiramate and thinking that I'm going to have to go and do an ARAF form. That's a bit of a stressful thing. I'm used to having a pregnancy prevention conversation with a patient. That I'm not worried about. The ARAF form I'm a little bit concerned about, I'll be honest. Anyone got any thoughts about anything? Anything at all on that front?
I think tomorrow's webinar is going to be very useful to hear it from different clinicians, the way forward.
Yeah.
And hopefully there will be some questions asked during the webinar as well. Nisha, this is a question for you. When we register for the event for tomorrow, we don't get the link. Would you be able to send the link to all of us, please?
For which event, sorry, Hala?
The sodium valproate and it's under the South West London Training Hub.
The sodium valproate and topiramate meeting.
Oh, that one.
Zara sent one out on that front.
I'm not actually managing that event. I can take this back to whoever is at the training hub. Zara might be doing it actually, but okay, I'll tell her.
Yeah, Zara was the one who sent it out. If we could just maybe prompt her just to resend it out.
Did you guys register? Because only if you register, you'll get the joining link.
I've registered.
Okay,
I've registered. If we could get the link sent out again, it'll be great. So we've got people saying limited progress with topiramate and valproate. Okay, fine. But more confident in the DOAC initiation. I'm initiating already, but don't prescribe yet. Absolutely fine. And that's good. So it means that when you go and actually do hopefully progress to that, you'll feel more comfortable. Good background information, would like to bring it to practice. Okay. Still worry about topiramate and valproate on that front. Current PPP forms are still struggle, more confident with DOACs. Perfect. Good information. Personally, like to do more training on the DOACs before supporting initiation. Absolutely, and I think that's fair. DOAC resources really helpful. Vibrate, we need more of a discussion. Absolutely, and I think that is completely fair on that front. So in terms of planning, so this is now putting it into practice on that front. What are you going to do to go and make that happen? What are you going to go and change in terms of go and try and plan? What do you need to plan ahead? So for that person who potentially is thinking about going and starting to go and maybe practice and start initiating or start going and doing more, what do we need to do more of about going for the pyramate sodium valproate? So for me, I'm going to that webinar tomorrow. That's the first thing I'm going to be doing because I'm going to that webinar. So I think that's going to be the key thing. So I think this is a word cloud one. So you just go and put in a couple of words. So it should be fairly simple, she says. I just don't think people want to talk to me today.
I think it's a quiet kind of day, Chadney. Oh, there you go. Maybe
So
there's a
further
delay.
training, raise awareness, search to ensure PP. I think that's great options. Absolutely great options. And is there
I
anything?
think the importance of all of this is, even though we've been prescribing for many decades for the sodium valproate and the topiramate, it's important to show how evidence evolve and change. And it doesn't mean once it's there, that's it, doesn't change. There's always this new evidence that comes, and we should be aware of it and then change the prescribing habits that we have. On a funny note, I think we were talking about eggs the other day, me and my friends, and how it was once upon a time looked at as it's not a good food option if you have high cholesterol. And that was the myth for many, many years. And then suddenly that changed. And then it's like, no, it's all good. You can eat as many eggs as you want. So even with that diet, it is how things change and evidence changes.
Yeah, it's very true. So we've got people going and saying further training, go to the webinar tomorrow, attend the webinar tomorrow, raise awareness, shadow someone who's doing it. That's a great idea. Ensure you search PPP and communicate changes. I think that's really important. So I think that's a great approach. And I think our final question, which I think is a really important one as well, on that front, how do you, as part of a team, do you think you can use your knowledge from today to enhance safety of prescribing in these clinical areas? So how is that going to benefit in terms of for safety today? How are you going to be able to go and improve that for patient benefit? And I'm going to put in a couple of minutes on that one, just because I know it takes a bit of time to type your answer for this one. I quite like my word cloud. I have to say, I like my word cloud, where it goes and gives me those spinny messages everywhere. I like this one too, but I like the other one better. So I might do more of these, more of the other ones next time, which you can't really write essays into. That's the only problem. Which is why I think I do this one.
I think my action plan is to speak to the prescribers and tell them to encourage them to go for the webinar tomorrow. Definitely that's something. I think even from a DOAC to discuss what is the way forward. Are we prescribing? Are we not prescribing? Yeah.
I think I'm going to talk to my neurology lead, who's the one who tends to do all the prescribe for the topiramate at the moment, or a bulk of it of initiation, because I think he obviously definitely needs to know about it because he actually works in the headache clinic. I don't think he knows about this. So that's going to be my action as well, is that do you know? I think that's going to be a bit of a shock for him going forward. So that's going to be an interesting one. So inform GPs at clinical meeting, ensure appropriate PPP conversation is in place when doing med reviews. Absolutely, that's a great one because that's something that's going to affect all of us. Communicate with the team. Where necessary, support education, support sessions, patient engagement, I think is going to be important. It's also patients actually know about it. So I don't think for the topiramate, a lot of people do know about it, to be honest.
Yeah, I agree.
Anything else from anyone else?
We've been having an audit, I think, for the DOAC. That is an action plan by itself, checking if the patient has diagnosis of astrofibrillation and not being prescribed a DOAC. That's another thing that you guys can look at. I think there's quite a few things for the DOAC perspective.
I think there's loads of things. I think people just are feeling a bit
Right.
on guard about it on that front. And someone's really loved the case study. Oh, bless, thank you. So I'm glad someone liked the case study. I like the case study on that front. So I think the key thing for me is that we need to do what's right by everybody. So we try and balance it out. So we try and do these sessions for all of your benefit. So the more you can get people you can get to come, the better it will be. I'm just putting the link in the chat for anyone who missed it last time to join the WhatsApp group, so we can try and support and try and circulate all of the information that's coming out, because all of this stuff is coming out, and sometimes it's really hard to be able to keep on top of all of those things that are coming through in the emails. So I'd like to be able to utilize this WhatsApp group to share that kind of stuff, so everyone can actually have quick access to it. And so we actually utilize it as not just a networking kind of side and being able to talk to people, but support session and sector to help everyone else. So that's the idea of it there. So it's there. Please feel free to join. We will keep the Telegram group as well, but we're hopefully trying to maneuver away from that a little bit. We're going to now, I'm going to stop the recording at some point. I think actually I was going to say, I think Nisha might have to do a bit of editing on that front. So we have our next session next